Patient safety is a new healthcare discipline that emphasizes the preventing, reducing, reporting and analysis of medical error that often leads to adverse healthcare events. The frequency and magnitude of avoidable adverse patient events was not well known until the 1990s, when multiple countries reported staggering numbers of patients harmed and killed by medical errors. Recognizing that healthcare errors impact 1 in every 10 patients around the world, the World Health Organization calls patient safety an endemic concern. Indeed, patient safety has emerged as a distinct healthcare discipline supported by an immature yet developing scientific framework. There is a significant transdisciplinary body of theoretical and research literature that informs the science of patient safety. The resulting patient safety knowledge continually informs improvement efforts such as applying lessons learned from business and industry, adopting innovative technologies, educating providers and consumers, enhancing error reporting systems, and developing new economic incentives. Prevalence of adverse events. Millennia ago, Hippocrates recognized the potential for injuries that arise from the well-intentioned actions of healers. Greek healers in the 4th century BC drafted the Hippocratic Oath and pledged to prescribe regimens for the good of my patients according to my ability and my judgment, and never do harm to anyone. Since then, the directive primum non nocere has become a central tenet for contemporary medicine. However, despite an increasing emphasis on the scientific basis of medical practice in Europe and the United States in the late 19th century, data on adverse outcomes were hard to come by, and the various studies commissioned collected mostly anecdotal events. In the United States, the public and the medical specialty of anesthesia were shocked in April 1982 by the ABC television program 2020 entitled The Deep Sleep, presenting accounts of anesthetic accidents. The producers stated that every year, 6,000 Americans suffer brain damage related to these mishaps. In 1983, the British Royal Society of Medicine and the Harvard Medical School jointly sponsored a symposium on anesthesia deaths and injuries, resulting in an agreement to share statistics and to conduct studies. By 1984, the American Society of Anesthesiologists had established the Anesthesia Patient Safety Foundation. The APSF marked the first use of the term patient safety in the name of professional reviewing organization. Although anesthesiologists comprise only about 5% of physicians in the United States, anesthesiology became the leading medical specialty addressing issues of patient safety. Likewise in Australia, the Australian Patient Safety Foundation was founded in 1989 for anesthesia error monitoring. Both organizations were soon expanded as the magnitude of the medical error crisis became known. Error is human in the United States. The full magnitude and impact of errors in healthcare was not appreciated until the 1990s, when several reports brought attention to this issue. In 1999, the Institute of Medicine of the National Academy of Sciences released a report Error is Human, Building a Safer Health System. The IOM called for a broad national effort to include establishment of a Center for Patient Safety, expanded reporting of adverse events, development of safety programs in healthcare organizations, and attention by regulators, healthcare purchasers, and professional societies. The majority of media attention, however, focused on the staggering statistics. From 44,000 to 98,000 preventable deaths annually due to medical error in hospitals, 7,000 preventable deaths related to medication errors alone, Within 2 weeks of the report's release, Congress began hearings and President Clinton ordered a government-wide study of the feasibility of implementing the report's recommendations. Initial criticisms of the methodology in the IOM estimates focused on the statistical methods of amplifying low numbers of incidents in the pilot studies to the general population. However, subsequent reports emphasized the striking prevalence and consequences of medical error. The experience has been similar in other countries. 10 years after a groundbreaking Australian study revealed 18,000 annual deaths from medical errors, Professor Bill Runciman, one of the study's authors and president of the Australian Patient Safety Foundation since its inception in 1989, reported himself a victim of a medical dosing error. The Department of Health expert group in June 2000 estimated that over 850,000 incidents harm National Health Service hospital patients in the United Kingdom each year. On average, 40 incidents a year contribute to patient deaths in each NHS institution. In 2004, the Canadian Adverse Events Study found that adverse events occurred in more than 7% of hospital admissions, and estimated that 9,000 to 24,000 Canadians die annually after an avoidable medical error. These and other reports from New Zealand, Denmark and developing countries have led the World Health Organization to estimate that 1 in 10 persons receiving health care will suffer preventable harm. Communication. Effective communication is essential for ensuring patient safety. Communicating starts with the provisioning of available information on any operational site, especially in mobile professional services. Communicating continues with the reduction of administrative burden, releasing the operating staff and easing the operational demand by model-driven orders, thus enabling adherence to a well-executable procedure finalized with a qualified minimum of required feedback. Effective and ineffective communication. The use of effective communication among patients and healthcare professionals is critical for achieving a patient's optimal health outcome. However, according to the Canadian Patient Safety Institute, ineffective communication has the opposite effect, as it can lead to patient harm. Communication with regards to patient safety can be classified into 2 categories: prevention of adverse events and responding to adverse events. Use of effective communication can aid in the prevention of adverse events, whereas ineffective communication can contribute to these incidences. If ineffective communication contributes to an adverse event, then better and more effective communication skills must be applied in response to achieve optimal outcomes for the patient's safety. There are different modes in which healthcare professionals can work to optimize the safety of patients, which include both verbal and nonverbal communication, as well as the effective use of appropriate communication technologies. Methods of effective verbal and nonverbal communication include treating patients with respect and showing empathy, clearly communicating with patients in a way that best fits the needs, practicing active listening skills, being sensitive with regards to cultural diversity and respecting the privacy and confidentiality rights of the patient. To use appropriate communication technology, healthcare professionals must choose which channel of communication is best suited to benefit the patient. Some channels are more likely to result in communication errors than others, such as communicating through telephone or email. It is also the responsibility of the provider to know the advantages and limitations of using electronic health records, as they do not convey all information necessary to understanding patient needs. If a healthcare professional is not practicing these skills, they are not being an effective communicator, which may affect patient outcome. The goal of a healthcare professional is to aid a patient in achieving their optimal health outcome. which entails that the patient's safety is not at risk. Practice of effective communication plays a large role in promoting and protecting patient safety. Teamwork and communication. During complex situations, communication between health professionals must be at its best. There are several techniques, tools, and strategies used to improve communication. Any team should have a clear purpose and each member should be aware of the role and be involved accordingly. To increase the quality of communication between people involved, regular feedback should be provided. Strategies such as briefings allow the team to be set on the purpose and ensure that members not only share the goal but also the process they will follow to achieve it. Briefings reduce interruptions, prevent delays and build stronger relationships, resulting in a strong patient safety environment. Debriefing is another useful strategy. Healthcare providers meet to discuss a situation, record what they learned and discuss how it might be better handled. Closed-loop communication is another important technique used to ensure that the message that was sent is received and interpreted by the receiver. SBAR is a structured system designed to help team members communicate about the patient in the most convenient form possible. Communication between healthcare professionals not only helps achieve the best results for the patient but also prevents any unseen incidents. Safety culture, as is the case in other industries, when there is a mistake or error made, people look for someone to blame. This may seem natural, but it creates a blame culture in a way who is more important than why or how. A just culture, also sometimes known as no blame or no fault, seeks to understand the root causes of an incident rather than just who was involved. In healthcare, there is a move towards a patient safety culture. This applies the lessons learned from other industries, such as aviation, marine, and industrial, to a healthcare setting. When assessing and analyzing an incident, individuals involved are much more likely to be forthcoming with their own mistakes if they know that their job is not at risk. This allows a much more complete and clear picture to be formed of the facts of an event. For that root cause analysis can occur, there are often multiple causative factors involved in an adverse or near-miss event. It is only after all contributing factors have been identified that effective changes can be made that will prevent a similar incident from occurring. Disclosure of an incident after an adverse event occurs. Each country has its own way of dealing with the incident. In Canada, a quality improvement review is primarily used. A quality improvement review is an evaluation that is completed after an adverse event occurs with the intention to both fix the problem, as well as preventing it from happening again. The individual provinces and territories have laws on whether it is required to disclose the quality improvement review to the patient. Healthcare providers have an obligation to disclose any adverse event to the patients because of ethical and professional guidelines. If more providers participate in the quality improvement review, it can increase interdisciplinary collaboration and can sustain relationships between departments and staff. In the U.S., clinical peer review is used. Uninvolved medical staff review the event and work toward preventing further incidents. The disclosure of adverse events is important in maintaining trust in the relationship between healthcare provider and patient. It is also important in learning how to avoid these mistakes in the future by conducting quality improvement reviews or clinical peer review. If the provider accurately handles the event and discloses it to the patient and the family, he/she can avoid getting punished, which includes lawsuits, fines and suspension.